is excochleation of the nodes. Excochleation of the nodes. In the brackets write, please, usually it is the choice surgery for the benign type of the tumors. For benign type of the tumors. Second one, it is portional resection of the thyroid. In the brackets write, please, it is performed usually in the sides of one lobe. And usually lobe is removed together with isthmus. And finally, last surgery we call strumectomy, or complete removing of the thyroid. The name is show what does it mean. We completely remove thyroid gland. In the brackets write, please, with keeping of parathyroid glands, with their vessels. That is very important. Let's say we don't remove the parathyroid gland. In the case of the malignancy of the thyroid, surgery doesn't used as the primary treatment. Usually we make the combination of the surgical treatment with chemotherapy or with the radiotherapeutical treatment. In case of distant metastasis from the thyroid, usually surgical treatment is not used at all, and we make the palliative treatment. In the brackets write, please, also can be performed palliative surgery. For example, palliative tracheotomy, tracheostomy. For example, palliative tracheotomy, tracheostomy. Technique of the surgery. Usually incision provided horizontally. Approximately 2-3 centimeters below inferior margin of the thyroid cartilage. 2-3 centimeters below inferior margin of thyroid cartilage. Or vertically from inferior margin of thyroid cartilage into 5-6 centimeters downwards by midline of the neck. Let's have 1 minute attention to me. We can make horizontal incision, approximately level I show for you. We can make vertical descending incision. Of course, from cosmetological point of view, as I said previously, horizontal incision in the medial triangle is much more preferable because natural folds has horizontal direction. Right, please. Layer by layer, we cut skin, subcutaneous fatty tissue. Platysma is not incised. We don't cut platysma. We apply the hooks in the margins, medial margins, and push it to the sides. Under the platysma, you see second fascia. Second fascia with third one fused to each other by midline of the neck. They form linea alveoli. As you remember, white line of the neck. That's like 1 minute attention. From this level, direction of your incision is changed. That's why you started incision horizontally, then you see the white line, you become to the vertical incision. That's why we provided changing incision. Direction of our incision is changed. That's why we cut the white line, and under of it we see infrahyoids. There are two methods with work of infrahyoid. I suggest you to cut two muscles. This is sternohyoid and sternothyroid muscles. Why? Minute attention, look to me. Some surgeons prefer to again apply the hooks and the enlarge, but it may critically small your surgical field. Because these muscles superiorly, approximately 3-4 centimeters upwards, fused with the hyoid bone. That's why it's impossible so much enlarge this aperture to have that. Let's say, don't worry guys, cut it, but very important point, cut it maximally near thyroid cartilage. Why it is necessary? To not damage ansa cervicalis. As you remember, ansa cervicalis, that is the nerve which is innervated all your infrahyoids. Yeah? From upwards it forms by hypoglossus, from downwards it is formed from cervical plexus. it is located below your thyroid gland. So then you cut the muscles in the level of the thyroid. You don't damage the main trunk of this nerve. Then you make it below, you can damage simply. Say, right, please, we cut the infrathyroid 2 muscles. 4 is not necessary, only 2. It is sternothyroid and sternohyoid muscles. Under of them, you see parietal and visceral layers of fourth fascia. As you remember, visceral one forms the facial capsule for the thyroid gland. Parietal forms the previsceral space. Now we need attention, look to me. Previsceral space is dangerous. Then you open it below the isthmus. Then you open it above the isthmus. It doesn't contain anything serious. As you remember, arteria thyroidea, which is supply the isthmus, and which can give formation of the tamponade of the heart, is located below the isthmus. It's a right, please, using the groove probe. Not 10%, but anyhow, Ziadja, even not all. They say you must be attentive. They say, look, Mama Jan, do you listen to me? Using the groove probe, we cut the parietal layer of fourth fascia. We make revision of the previsceral space. Anyhow, normally, what do you see here? Normally, you see here the venous plexus of the thyroid. Yeah? If it is in front of you, ligate and cut, no any matter. Finally, you open the thyroid gland. Now, right, please. When the thyroid gland is visible, using the scalpel, you cut the facial capsule. Near the lateral margin of the lobes. We need attention into the picture. That is our thyroid gland. You take the scalpel and near the lateral margin of the lobe, you cut. Why I don't draw it from 2 sides? There are the rule of the thyroid surgery. Firstly, work with one lobe. Finish your work with one lobe. Then only go to the opposite side if you need to make the total resection. If you need to make the one lobular resection, just you work in one side. Doesn't matter which one. All consequence of the steps will be same. That's why we don't make at once incision in both sides. We make incision in one side. What do you cut it? You cut it only facial capsule. Don't forget that your thyroid has 2 capsules. Under the facial capsule, we have the fibrous capsule. That's why you strongly use the groove probe to not damage the fibrous capsule and to not damage the structures between 2 capsules. Consequence of work, you know, by dissecting forceps, you fix the facial capsule, little bit lift it, using the scissor, you make aperture, you insert it groove probe inside of the space, and according to the groove, you cut the facial capsule to not damage internal structures. Okay, I cut it facial capsule. What I see exactly under of it? First of all, I see 3 big veins, which is enter inside, which is go out from thyroid gland. First one, it is superior thyroid. Second, it is middle thyroid. And third one, it is inferior thyroid. Main vein, which is main fixation of the thyroid gland, it is middle thyroid vein. That's why first of all, you apply 2 ligatures on the middle thyroid vein and you cut it. Under the middle thyroid vein, just in the posterior surface of the tongue, you can write, guys. That's why first of all, we make mobilization after cutting of the facial capsule. We make mobilization of thyroid gland, which is divided into 2 steps. Step number 1, we ligated middle thyroid and cut it. Step number 2, under the middle thyroid, we see the Barry's ligament of the Barry. As you remember, it is the suspensor ligament of thyroid. Now, 1 minute look. If I will be a lobe of thyroid, belly ligament from mid-side of my lateral portion, yeah, goes to the trachea. And it is main fixation of thyroid into the trachea. So after ligation of the vein, you apply 2 arterial forceps in this belly ligament. It is strong. It's not. It is forbidden just to cut it. Why? Because it has great supply. That's why you apply 2 arterial forceps, you cut it, and you make suturing with ligation. Let's say you inserted needle with the ligature in each end for fixation of the needle, and you ligated both ends of the bearing ligament. You should be critically attentive here, because under of your bearing ligament, sometimes you can see inferior thyroid artery. Approximately 20. Usually it is located on the level of the inferior lobe, but sometimes it can be ascended and pass behind of the bearing ligament. Let's say to be very attentive to not damage inferior thyroid. Okay, let's say we make a little bit medially to it. We see external branch of superior laryngeal nerve, which is from vagus. In front of it and little bit medially to it, we see external branch of superior laryngeal nerve. Now here there are two rules. Rule number one. As you know, superior thyroid artery forms neurovascular bundle. Yeah, and this neurovascular bundle also covered by the parietal layer of the fourth tissue. It is artery, it is vein, and nervus laryngeus superior. External branch, because in some persons, some surgeons make bulk ligation of the superior pole. What does it mean? They apply arterial forceps just in the tissue of the thyroid gland. They cut and suture this place, yeah? This is also forbidden, because then you make bulk ligation, you damage small branches of nervus laryngeus superior inside of the thyroid tissue. Do you understand or not? Let's say, remember please, usually bulk ligation is not the choice manipulation. Remember once again, first one, separate ligation of the artery. Second one, it is ligation maximally near to the tissue of the thyroid. Continue please. After ligation of superior thyroid vessels, first of all artery, then the vein, we go to the inferior pole of the thyroid gland. And approximately 1-2 centimeters above inferior pole of thyroid gland, we see second neurovascular bundle, which I draw by the green color here. It is inferior thyroid vessels, artery and vein, and nervus laryngeus recurrens. Unfortunately, guys, this neurovascular bundle is not so strong positive as the superior one. First of all, its position can be changed. Sometimes I say it is behind of the bearing ligament. And second syncope of element is very changeable. 50% second syncope of element is very changeable. 50% nerve is located in front of artery. 50% nerve is located behind of artery. But anyhow, to find this nerve, it's not make any problem because it is very thick. For example, external branch of superior laryngeal nerve twice thinner than nervus laryngeus recurrens. So if you will be attentive, you can easily find this nerve. By the way, nerve is enter inside of the thyroid gland approximately 1 centimeter below the artery. So first of all, nerve is inserted inside of the gland. Then 1 centimeter above the nerve, artery goes inside of the gland. That's a rule which I say for superior one, absolutely samely work for inferior one. Make separate ligation of the vessels and make ligation maximally near to the tissue of the thyroid gland. Again I say, these two structures, inferior thyroid artery and recurrence laryngeal nerve, enter inside of the thyroid gland in different places. Nerve is more down, artery more up. Let's continue, please. We make ligation of the inferior thyroid artery. By the way, all arteries ligated by 3 ligatures, as I teach you before. 2 ligatures in the proximal end, 1 ligature in the distal end. Then we cut, because this is the middle diameter vessels. They can give the secondary bleedings. Finally, we ligated the inferior thyroid vein. Ligation of thyroid. This is rule, guys. Remember, only middle thyroid vein ligated before ligation of the arteries. All another veins, superior and inferior, will ligate it after ligation of the arteries. You can ask me why. To give the chance for the blood leave the thyroid gland. If you will ligate it, first of all, the veins, a lot of the blood will be removed together with the thyroid. Because you close the drainage ways, and then you ligate the artery and remove big bulk of the blood. You know, thyroid gland has huge supply. That's a rule only for middle one. Middle will ligate it before arteries. This is not the problem because another 2 arteries is open. All another arteries will ligate it after ligation. All another veins will ligate it after ligation of the artery. Right, please. After full mobilization of the thyroid, on the posterior surface of it, we recognize parathyroid glands, which has brown color and which is 4, 2 superior and 2 inferior. By the way, guys, why I tell you that ligated inferior thyroid artery maximally near to the thyroid tissue, not only to not damage the nerve, but also to not close the parathyroid branches, which goes to the thyroid gland. Now, minute attention, look to me. From this inferior thyroid artery, parathyroid vessels is originated, which is come to the both and superior and inferior parathyroid glands and supply them. What is the problem? Then you make ligation near the tissue, you don't damage the supplyment of the parathyroid glands. If you will make far ligation in distance, for example, not only the main supplyment will be destroyed, which is necessary for us, but also we will close supplyment of the parathyroid glands. As I remember, it is also some surgeons even make the microsurgical procedure. They find only branches of inferior thyroid artery, which go to thyroid gland only, and ligated it. Why? Because inferior thyroid artery gives the branches not only to parathyroid, but to the trachea, to the esophagus. Let's say there are big problems if you will make ligation in distance. You can damage arterial supplyment of parathyroid glands, the trachea, esophagus. Let's say you will have necrotization of these structures. By the way, approximately in 10% of the cases, strumectomy damages the parathyroid glands. A person after all the life must intake the parathormone. Otherwise, the strokes, I'm